Good evening, everybody. Welcome to this evening episode of Pursue. We are back after the festival season and we are starting with Pursue 20F, which is Transfusion Medicine. We are streaming live from PGIMER Chandigarh via Kolkata. And we have Dr. Lakhvinder Singh to start our post-festival sessions and a very interesting topic, autologous transfusion and alternatives of blood transfusion. Dr. Lakhvinder Singh is an MBBS and MD in transfusion medicine. Presently, he is an assistant professor in the Department of Transfusion Medicine, PGIMER, Chandigarh. He is a member of the Patient Blood Management Subgroup of Clinical Transfusion Working Party, International Society of Blood Transfusion. He was awarded the PGI Fellowship Award first rank at Transcon 2011. He's got multiple publications in international and national journals to his name. He's member of the manuscript review panel of IJHBT, AJTS, and IJPE, some of the leading journals of transfusion medicines. His areas of interest is clinical transfusion practice, patient blood management, Hemovigilance, on which he has taken a very good lecture, and Immunohematology. Today he will be talking on autologous transfusion and alternatives of blood transfusion. Before I ask Dr. Lakhvinder to start, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. With this, I would request Dr. Lakhvinder sir, please share your screen and let us start.
Thank you so much, sir, for your kind introduction again. And let me start the screen. Yes. Is the screen visible, sir?
Yes, absolutely visible. Just to press that hide pop-up so that goes away. Perfect. Please start, sir.
Yeah, thank you so much, sir. So the topic for today is autologous transfusion and alternatives of blood transfusion. And so let me get some disturbance. Yeah. So coming to autologous donation or transfusion, the definition we discussed was, it means blood and blood components which are collected from an individual and intended solely for subsequent autologous transfusion to the same. Am I audible?
Yeah, absolutely audible.
There's some disturbance, I think. There's some disturbance in the sound. I think somebody is unmuted.
No, you are muted. You are unmute. You can start. Continue. Please go ahead.
So for autologous donation, you call it autologous donation or transfusion. It means the same thing because the blood donor as well as the recipient are the same. We take the blood from the patient, process that blood, and transfuse that blood back to the same patient. So the blood and blood components are collected from an individual and intended solely for the same individual. We have three types in the autologous transfusion. One is the pre-deposit autologous donation, PAD. In this, before an elective procedure, we take the blood 1 unit, 2 units as per requirement, and then we keep that blood in the blood bank. And when required, then we issue that blood and that is transfused. Second is acute normovolemic hemodilution. It is ANH. In this, a patient who has a good HB like 11, 12, and we know that the surgery patient is going to undergo, is going to have a massive blood loss, or 400 to 500 ml of blood loss is going to be there. So what we do is we take 1 unit of blood before the surgery. So that blood we have taken out is of high hematocrit, good platelets, and good coagulation factors. Once a patient starts bleeding, we give crystalloids. The hematocrit gets diluted, and the patient bleeds less hematocrit blood. And at the end of surgery, we transfuse the blood which we had taken at the beginning of the surgery. I'll discuss all this in detail. And third is the cell salvage. It can be done during intraoperative phase or in the post-operative phase as well. Coming to why do we need autologous blood transfusion? Firstly, concerns about viral transmission. It actually started in 1980s when the risk of HIV transmission had increased in India also and across the globe as well. That's why the people were very hesitant to take the blood from others. And at that time, there was no nucleic acid testing, no very good ELISA techniques were there. So there was risk of viral transmission. So people used to get the autologous blood transfusions done. But nowadays, since we have a very good test like ELISA, nucleic acid testing, so safety of blood is not a concern anymore. Second was alloimmunization. A patient who has developed antibodies to a multiple antibodies or antibodies to a particular antigen which is very rare, in that case it becomes difficult to find a compatible blood. So in those cases also autologous blood can be of good use. Third is less incidence of transfusion reaction. Initially they used to think we are transfusing the same blood from the same donor to the same recipient, so there will be no transfusion reaction, but that's not true, because there is a difference between the autologous blood and the blood which has been kept in the blood bank. There are some storage lesions which occur in the blood during storage, and those storage lesions can cause reaction. So incidence is less, but yes, reactions can occur even after autologous blood transfusion also. Patient with rare blood groups, like somebody has a Bombay blood group, so we can't find a Bombay donor. So in that case, we can go for autologous blood transfusion. Jehovah's Witnesses, it's a religious community mainly in the UK. So have a good number of people residing in UK. These people do not accept allogenic blood. Allogenic blood means blood from some other individual. So for these kind of patients, autologous blood transfusion is being practiced in UK. Other concern with autologous, risk of bacterial contamination is there, because the patient may not be healthy, may be having some kind of infection. If it's being kept outside in the operation theater or some other problem occurs, then risk of bacterial contamination is still there. Transfusion reaction, as I already explained, storage lesion. Febrile reaction, because when I explained the adverse reaction, I said febrile reaction may be because of two reasons. One is the immune and one is a non-immune. In the immune cause, some leukocytes related factors are there, which will not happen with autologous blood transfusion. But during storage, the monocytes, the neutrophils, they degranulate, release some cytokines, and those cytokines can cause febrile reaction. So blood, even autologous blood, if banked in the blood bank for more than 4 to 5 days, it can cause febrile reaction. Clerical errors, because autologous blood donation are done in the OTs. So in a hurry, there are chances that you mix the blood. Then it can cause ABO incompatible transfer or wastage of blood if not used. Nowadays, not many autologous transfusions are being done, because a person who is capable to give blood or to donate blood preoperatively has less chances that he or she would require blood during the transfusion. So in that case, blood is not used, and that particular blood you cannot use for any other patient. So it leads to more wastage of blood. So coming to the first part, pre-deposit autologous donation. In this, patient blood is collected and stored prior to elective procedure, elective surgery. A healthy adult patient can donate up to 3 red cell units before elective surgery. And you can give him iron supplements or growth factors to prevent anemia or allow more number of donation before the procedure. Indications for a preoperative autologous donation is the likelihood of transfusion is more than 10%, because if patient likelihood is less during the surgery, then there's no point of collecting the blood. Elective surgery to be scheduled at least several weeks in advance. Patient with bleeding tendency, but who are not currently anemic or bleeding. Patient with alloantibodies where allogenic blood may be in short supply, as I've discussed, and patient at serious psychiatric risk because of anxiety about exposure to donor blood. It's a very important factor, and very commonly we find such patients who get anxious after you transfuse them allogenic blood. So PAD is an option for them as well. Contraindications, patients who have already had bacteremia, because once the blood goes in vivo, the bacterial the multiplication of bacteria may increase. Patient with indwelling urinary catheters or device penetrating skin, those cases we do not go for PAD. Special consideration may apply when certain medical conditions are there, like unstable angina, cyanotic congenital heart disease, severe aortic stenosis, severe occlusive cerebrovascular disease. So you should not risk the patient, because if you take out 500 ml of blood from a patient, it should not risk his own condition. So you have to assess the patient and then decide whether do you want to go for PAD or not. Then donor selection criteria, they are not as stringent as normal blood donation criteria. In this, we have to get the written consent. There is no age limit. Even for infants also, depending on the requirement, you can take the blood out. I mean, from an adult, will take a whole bag, but from a child, you may require 50 ml, 40 ml that you can consider taking. But in normal blood donation, the age is 18 to 65. But here, there is no age limit. For weight, no requirement, but you cannot take more than 8 ml per kg body. Then hemoglobin is 11 gram per deciliter. It has to be more than 11 gram per deciliter. However, in normal blood donation, it's 12.5. So coming to the second, acute normobulimic hemodilution. In ANH, several units of blood are collected into standard blood donation pack immediately before surgery, usually in the operating room. The patient blood volume is maintained by the simultaneous infusion of crystalloids or colloid fluids. Now you see here, before the surgery, we have removed the blood. Now this blood has good amount of hemoglobin, platelet factors, and coagulation factor. Now you have replaced that blood with crystalloids. Now the blood flowing in vivo in the patient is having low hematocrit, low platelets, and low coagulation factor as compared to the blood you have taken out. So when the patient will bleed during the surgical procedure, patient will bleed low hematocrit blood. So that's how you are preserving the hematocrit, platelets, and the coagulation factors. So the blood is stored in the operating theater at room temperature and reinfused at the end of surgery, or if significant bleeding occurs during the surgery. The first unit collected is to be transfused last, as it contains maximum hematocrit, platelets, and clotting factors, as I've already explained. ANH is most often using cardiac bypass surgeries, where the immediate post-operative transfusion of fresh whole blood containing platelets and clotting factor is seen as an advantage, because lots of blood is lost during the bypass surgery. The blood goes into circuit, most of it is discarded. So it's better that you take out the blood first, and this cardiac bypass patient, they are less prone to develop other complications. Reported hazards are fluid overload, cardiac ischemia, wrong blood into patient due to patient errors. But mathematical modeling suggests ANH is most effective as a blood conservation measure in surgery with major blood loss. Now, uncommonly elective cardiac surgery also. Systematic review of published trials have found no significant reduction in exposure to donor transfusion compared to standard care or other blood conservation techniques, and the safety of ANH remains unclear. So I've already explained, the person who can donate blood would be having a good HB, would be healthy as compared to other patients. So these patients are unlikely to require blood, and sometimes patient doesn't require blood, but we have blood in hand, so we have to transfer it back. So it has its own adverse effect. So again, the use of ANH has decreased, and various studies have found that if we have taken out 1 unit of blood and the patient starts to bleed, after 1 unit of blood, you have to give allogenic blood as well. So there is no significant decrease in the exposure to allogenic blood. So the purpose of doing ANH is not resolved. So that's why nowadays, again, it's not a very good modality. It's reserved only for patients who are undergoing bypass procedures. Criteria, preoperative hemoglobin should be 12. There should not be clinical significant coronary, pulmonary, renal, or liver disease, absence of severe hypertension, absence of infection, risk of bacteremia. Then comes a third, intraoperative cell salvage. In the first preoperative autologous donation, we had taken the blood a week before the surgery. In acute normovolemic hemodilution, we have taken the blood just before starting the procedure. And now third is cell salvage intraoperative. During the surgical procedure, some blood is lost. This bleed and that blood generally goes into the bin. But if you are able to take that blood, wash that blood, and transfuse that blood back to the patient, that it will again preserve the hemoglobin. We have commercially available largely automatic devices. What happens with the suction machine? The blood is sucked into the machine. It is then filtered for any bone chips, for any for some fascia, skin, or any other biological thing, and then it is washed so the other debris, plasma is removed, any drug is removed, only red cells are there. They are washed and then they are reinfused. So I just read the second line again. Commercially available, largely automatic devices are available for ICS and are now widely used in hospitals for both elective and emergency surgery with significant blood loss and in the management of major traumatic or obstetric hemorrhage. This is being used nowadays. The machines must always be used and maintained according to the manufacturer instruction by appropriately trained staff. Because if machine is not working properly, your staff is not trained, so you are doing trauma to the red cells also. If the red cell get hemolyzed and then they are transfused, they will cause more harm than any benefit to the patient. So these things are very, very important to consider. And a review of randomized trials, they say mainly in cardiac and orthopedic surgery, there is a 20% reduction in donor blood exposure. So average saving of 0.7 units per patient is there. So indications are I'll in the list paper. The procedure for intraoperative cell salvages, blood loss into surgical field is filtered to remove particulate matter and aspirated into a collection reservoir where it is anticoagulated with heparin or citric. If sufficient blood is collected and the patient loses sufficient blood to require transfusion, the salvaged blood can be centrifuged, washed in a closed automatic system. Red cells suspended in sterile saline solution are produced, which must be transfused to the patient within 4 hours of processing. The reinfusion bag should be labeled in the operating theatre with a minimum patient identifiers derived from the patient ID band. This UK CSHG, they have developed a suitable label for this purpose because they are doing it in a routine manner. Then the red cells are transfused to a 200 micrometer skin filter as in a standard blood administration set, except in those instances where a leukodepletion filter is indicated. For leukodepletion filter, it is indicated in those conditions where, like in some cancer surgery is being done. So we are scared that some cancer cells may get reinfused. So for that, we use a leukodepletion filter. The transfusion should be prescribed, documented, and patient monitored in the same way as for any other transfusion. And the patient undergoing elective procedure where intraoperative salvage may be used should give informed consent after provision of relevant information. Like we give all the side effects and everything to the patient. So indications are these for intraoperative salvages: surgery where the anticipated blood loss is more than 20%, elective or emergency surgery with risk factors for bleeding, major hemorrhage, like patient comes with the postpartum hemorrhage, traumatic hemorrhages. In that case also, if we have the machine in the trauma centers or the labor rooms, then we can practice this. Patient with rare blood groups or multiple blood group antibody for whom it may be difficult to provide donor blood after the procedure. Patients who do not accept donor blood, like Jehovah's Witnesses are there, or do not give the consent for ICS. Special cases are there, like patient undergoing bowel surgery. Lot of fecal matter is there, lot of contamination is there, bowel is full of bacteria also. So we avoid doing ICS with bowel surgery. Cancer cell surgeries, so concern about cancer cell infusion is there, reinfusion, sorry. So So, but still, it's not a risk factor. So, it is recommended to reinfuse the red cell through a leukodepletion filter, so that cancer cells are also filtered through it. In obstetrics, there are chances of amniotic fluid embolism are there. So, still, we say that if you transfuse through a leukodepletion filter, then the chances would be less. So, for intraoperative salvage, two conditions where leukodepletion filter is to be used is cancer surgery and obstetrics. And during bowel surgeries, ICS is not to be used. Coming to the post-operative cell salvage, post-operative cell salvage is mainly using orthopedic procedures, especially after knee or hip replacement and in correction of scoliosis. Those conditions where you expect that post-operatively also the patient is going to bleed into the drains. It's mainly the orthopedic procedure because the small vessels get ruptured in knee and hip replacement. So for 2 or 3 days, patient keeps on bleeding in the drain. So that blood is collected from wound drains and then either filtered or washed in automatic system before reinfused. Not more than 500 to 1000 ml is to be used. And one thing you have to keep in mind, that recovered blood, let me highlight it because this is an important point. Recovered blood is dilute, partially hemolyzed, defibrinated because it's a bleed from the drain. So fibrin, of course, won't be there and may contain high concentration of cytokines. So the volume you transfuse should be low and should be, when you wash the cells, you have to be very careful that the cells are not lysed. If they are lysed, do not transfer it. So with this infusion volumes, concern about adverse effects on blood coagulation have not been confirmed in routine practice. The staff must be trained and competency assessed to use the device, accurately document the collection, label the pack at the bedside, because in case if some hemolyzed blood is transfused, it may cause severe reaction. The patient may even die. So these things are more important than to purchase the machine. Collection of salvage blood must be completed within the manufacturer specific time, and the reinfusion must be monitored and documented in the same way as donor transfusions. It's PCS is relatively cheap, so for Jehovah Witnesses you can use it. They do accept this. It remains unclear whether it adds significantly to a comprehensive blood conservation program, which includes preoperative optimization of HB, hemostatic, because nowadays we have some drugs also like Trenexa is there, aprotinine is there, which reduce the blood loss in the post-operative phase. I'll discuss those drugs as well. So if you are able to reduce the blood loss, then the role of post-operative cell salvage is not there. So we have to actually see if we can give those drugs and reduce the blood loss, then you cannot collect 500,000 ml of blood. So it's always an individual assessment. So now I have covered the autologous blood donation, 3 types: preoperative, autologous donation, acute normovolemic hemodilution, and the cell salvage, which can be intraoperative or postoperative. After that, I come to the alternatives of blood transfusion. If not blood transfusion, first was we give allogenic blood. If patient is not accepting that, there are some reasons you are not able to give allogenic blood, you can give autologous blood. If the option of autologous blood is also not there, then what to do? Then you can think of some alternatives of blood transfusion. So if you ask me, there is no true alternative to blood developed as yet, which has all the properties of blood. So we have the various alternatives, like we have the various blood substitutes for red cell, platelets, plasma, which can be used as a substitutes, which are still in the trial phase. Second alternative would be to decrease the requirement of blood components. We have the pharmacological agents, which I just discussed, like which decrease the blood loss. If blood loss is not there, then blood would not be required. And other recombinant hematopoietic growth factors. They improve the blood production in the body. If the blood production can be increased, then it's good that patient would not require blood. Like in patient with some malignancy or the patient is undergoing some sort of chemotherapy and would require blood every week. But if you give erythropoietin or if you give your this filgastrin, it will increase the neutrophil count, the red cell count by erythropoietin, so patient would not require blood. So these are the various other alternatives which can be used. I'll discuss all these alternatives one by one. So blood substitutes, these are the ex vivo produced therapeutic materials with potential to replace or reduce transfusion requirement of blood and its blood components. Substances that mimic some of the function, not all the function of blood. So we have the real blood substitutes, red cell substitutes, platelet substitutes, and the white blood substitutes. I've used the word real. We have some virtual blood substitutes also. They are the other materials like your recombinant factors, your recombinant coagulation factors. They are not the real one. They are virtual substitutes because they are not substituting the blood. They are actually decreasing the requirement of blood. So real substitutes are these three: red cell, platelets, and white blood substitutes. However, white blood substitutes are not used. A few examples are your donor T lymphocyte infusions, where you can think of growing the WBCs in culture, but again in the trial phases. So mainly which have the potential that in near future maybe we'll start using the red cell substitutes or the platelet substitutes, not the white blood ones. So coming to the red cell substitutes, ideal characteristics are it should be an oxygen carrier, should be a blood volume expander, increased availability, universally compatible, free from pathogen, TTI, and transfusion reaction, viable over a wide range of temperature, and longer shelf life and cost efficient. But till date, we don't have any ideal red cell substitute available. Main two which are there in the market are our hemoglobin-based oxygen carriers and the perfluorocarbon molecules. Hemoglobin-based are the ones that hemoglobin is out of the red cell and it carries the oxygen. And we all know once hemoglobin is outside the red cell, it's a very toxic molecule. So various combinations have been tried to reduce the toxicity, which I'll discuss. And perfluorocarbon compounds are the one chemically they are the carbon compounds with fluoride atoms attached to it. It has a capacity that it can combine to large volume of oxygen, and if these are infused, the oxygenation to the various sites would be improved, but the free oxygen will increase, not the hemoglobin bound oxygen. Let's discuss this in detail. So hemoglobin based oxygen carriers are purified hemoglobin compounds stripped of its red cell stroma and reduced to the fundamental oxygen carrying component. We have three types: stroma free hemoglobin, cross-linked, or microencapsulated. So stroma free is hemoglobin is out of the red cell. It has a short half-life. It is very toxic. We all know after HTR, the hemolytic transfer reaction, the free hemoglobin comes out, so it can cause acute renal failure, hemoglobin urea, it being an oxidizing agent, and the teletoxicity can occur. Oxygen radicals are released. And second one, which I highlighted, is modulating vascular tone via effects of nitric oxide. And in the diagram, you can see that inside the red cell, it remains in this stage, and 2,3 DPG is there, which helps in the transport of oxygen to the various tissues. But when it is out of the red cell membrane, then it becomes free hemoglobin, and even at partial pressure 50, the pressure is very less, and it changes to a dimeric molecule. And in dimeric molecule, there is no 2,3 DPG. So it will keep the oxygen with inside this its own chains and will not release the oxygen. So it will have an effect on the oxidation dissociation curve as well. That's why it was tried but never used. So there came the hemoglobin modification. What they did was to 4 types of modification over there, polymerized hemoglobin. They polymerized it. They combine various molecules of hemoglobin and they link them with various molecules. Some use didaxin, some use oxynols, various different molecules were used with antioxidant enzymes. So the oxidant properties also go down. So we have two types, intermolecular or intramolecular cross-linking. Then conjugated. In this, you can see here, to stabilize the hemoglobin molecule, some like some protein or some other molecule are attached so that maintain the stability of the molecule. Then the recombinant. Some linkages were created, cross-linking, so that the tetrameric molecule doesn't change into the dimeric molecule. And fourth one is the encapsulated hemoglobin. Till date, this is the one which has reached advanced stage of the trials. In this, the hemoglobin molecule is being encapsulated in various proteins. I'll come to this part again. So cross-link I've already explained, do not break in dimeric fragments. Like this is the one segment of hemoglobin, maybe, I don't know, if it is alpha chain. So in this, they have added 2,3-DPG. So it binds to molecules. So change in surface configuration is there. It becomes unrecognizable by the host immune system. Mainly the 2,3-DPG is used. Then conjugated hemoglobin, soluble hemoglobin polymers cross-link to a large inert molecule. It improves the circulation time because the tetrameric form is maintained. So agent use are polyoxyethylene or polyethylene glycols that they use. Recombinant, they are made to join each other by various molecules by recombinant technology. One is the Optro, first generation. They fuse two alpha units. There's no renal toxicity because it's a large molecule. It cannot cross the your renal epithelium. It remains a tetrameric molecule. Second generation, first generation, all the features plus blockage of nitric oxide receptor site. These are again in that phase 2 or phase 3 trials of for this research. Microencapsulated hemoglobin, stroma-free hemoglobin enclosed in artificial membranes made from phospholipids or synthetic membranes. These membranes are more stable, has no blood group antigen. Artificial cells do not react with blood group antibody. So this is basically a false red blood cell which is created. Although these cells have proved effective in carrying oxygen in rats, they have a very short stay in circulation after intravenous injections. So what are the problems which I face? Supply challenges there, immunological response to various red cell are there, increased oxygen affinity because the PG does not bound. Cross-linking has decreased oxygen affinity, but optimizing the oxygen delivery in vivo, it's again a difficult thing to manage. Then vasoactive property because of nitric oxide. However, many things have been taken care of with ongoing research, but an ideal hemoglobin molecule is yet to be discovered, which can be used as a substitute for the red cell transfusion. So after the hemoglobin-based red cell substitutes, we have the perfluorochemical compounds. They are organic compounds with fluorine. They dissolve 40 to 70% oxygen per unit volume, almost 3 times the oxygen capacity of blood plasma. It is non-antigenic because it's a chemical compound, do not carry carbon monoxide, shelf life is 2 years, minimal risk of infection, immunological transient reactions would not be there. PFC dissolve oxygen, which allows them to load under oxygen 2 times faster than HB and extract 90% of the transported oxygen. So small particles of PFC can penetrate occluded vessels in cerebral ischemia or myocardial infarction. Thrombus is there, blood is not able to reach, there is no oxygenation, ischemia occurs. But if PFC are given, they pass that thrombus and they can provide oxygen to the ischemic areas in MI or cerebral ischemia. PFC have been licensed for use in percutaneous transluminal coronary angioplasty. They have been used in the West, but I doubt if somebody in India has used this compound. They have to emulsify before administering intravenously. And since emulsified PFC have little osmotic and oncotic pressure properties, electrolytes and plasma volume expander must be added to provide these needs. Flusol DA, developed by Japanese, it contains two types of PFC in a mixture of electrolytes, lecithin and hydroxyethyl. That this is being used. So first generation is the flusol DA 20% used for ischemias, auxiliary vessels, and these type of problems. Second generation, it is in the phase 2. It is sensitizing tumor before radio chemo to increase oxygenation and increase the stroke. And third generation oxysites, they call it. It's used for traumatic brain injury. We're still in the trial phase, but flusol has been used in MI for experimental purposes. Disadvantages: oxygen level in PFC solution equilibrates with oxygen level in atmosphere, which is not true for hemoglobin. It requires administration of 60 to 100% oxygen. It may even cause oxygen toxicity if the more of oxygen is released. And emulsions of PFC are unstable, resulting in need for a frozen stage. And PFC can be retained in liver and spleen, may cause even liver failure also. So these are the examples of various hemoglobin-based or perfluorocarbons. What are their names and where they have been used? I just added this slide so that it completes that list. So, probably I won't be able to enumerate all things together, but you can see here that liposome and encapsulated hemoglobin pre-clin phase it has reached, including your this conjugated and encapsulated. Perfluorocarbons, they have been licensed in Russia and Mexico with the name of perforate, is basically flucosol. So after the red cell, let's come to the platelet substitutes. We have two types, platelet derived and synthetic platelet substitutes. Platelet derived are basically not platelet substitutes. They are derived from platelets only. But these are different from the standard platelets we use. Platelets are stored at room temperature, but these are lyophilized. You lyophilize them, then store them for a longer period of time. When required, you can use it. Then platelet derived microparticles. These are being extensively used for research these days because they have the capacity to initiate or augment the coagulation in vivo without increasing the immunogenicity. And culture-derived platelets can also be used. Synthetic platelet substitutes. These are the main platelet substitutes. One are the thrombospheres. You must have heard the name. They are the fibrinogen-coated albumin particles are there. Albumin molecule is covered by fibrinogen. So it helps in initiating the coagulation. In fusible platelet membrane, it activates the adhesion and aggregation pathways and promote clot formation. And third are the liposome-based agent. I'll discuss all these. So coming to the platelet derived, which are not the actual platelet substitutes, false platelet substitutes. Lyophilized platelet, it is prepared by using 1.8% paraformaldehyde and it is freeze-dried with 5% albumin. Rehydrated platelets after thawing have a similar appearance to fresh platelets and have most of the same surface protein levels. Platelet-derived microparticles. These platelet microparticles are microvesicles of platelet membrane and formed during storage. Similar hemostatic properties as intact platelets produced from outdated platelets. Even after the outdatation of platelets, these microparticles can be used. Culture-derived platelets in 1995. The process of growing platelets in lab from megakaryocyte progenitors was described. The resulting platelet appear to be functionally and morphologically similar to fresh donated platelets in vitro, but still it's in the research phase. So coming to the synthetic platelet substitute, fibrinogen-coated albumin microcapsules. In this, fibrinogen has been used to coat microspheres of human protein albumin. Two preparations have been evaluated, synthesized and the thrombospheres. It just differs in the composition of fibrinogen and the albumin. Thrombospheres have a smaller mean diameter, and in vivo studies suggest that they may have a longer duration of action as compared to the platelet. Second are the liposome-based agents. Two liposome-based agents are there. 10A with phospholipid vesicles, These plateletosomes are lipid vesicles with platelet glycoprotein on the surface so that the coagulation can be activated. They both are hemostatically effective in vitro and in some animals models, but latter was associated with high toxicity. So this is again one molecule which I came across, polyhemoglobin fibrinogen. It has hemoglobin at the center covered by fibrinogen. So it will have the oxygen carrier capacity of hemoglobin also, and fibrinogen will act as the platelet activity also. So it has properties of both, but still it's in the trial phase. So after the after the blood substitutes, now coming to the recombinant hematopoietic growth factors, which accelerate the production of red cells, platelets, and your WBC neutrophils monocytes, so that the requirement for the transfusion of these components decreases. And these have been again extensively used. So this diagram just shows that we have the totipotent, pluripotent stem cells are there from two lineages come, one the lymphocyte progenitor and we have the GMM. The myeloid series starts from here, the megakaryocytes bunch out and platelets are formed. From here we have the this erythropoietic act and the blast-forming units are there for red cells are prepared. From here the granulocytes are formed and monocytes are formed. So this is GMCSF. So this would be GCSF. G means only granulocyte CSF. GM would, if it form granulocyte monocyte CSF, and this is the for megakaryocyte. This is I'm highlighting because that's how these cells are being prepared. So in practice, most of these interleukin are being used, but maximum use are the erythropoietin molecule. The recombinant erythropoietin molecule are there, like we have Nanocarp is there, Aprofin is there. So these are the molecules which stimulate the red cell production. Then filgrastim is there, which is GCSF, which is being used for to increase the production of neutrophils. Then we have the thrombopoietin agonists are there, which increase the production of platelets. So coming to the recombinant hematopoietic growth factors, we have the erythroid growth factors, myeloid growth factors, megakaryocytes, which I have already explained. In erythroid growth factors, erythropoietin is there. From there, we derive these two molecules, epoetin alpha and darbepoetin alpha. Then myeloid growth factors are there. In this, we have the GCSF. GCSF will stimulate only the granulocytes, like neutrophils only. So the main molecule which are used are filgrastim, then tibiofilgrastim, it's the derivative of filgrastim, and pegfilgrastim. Then we have the GMCSF, which is the granulocyte monocyte colony stimulating factor. It is cedramostin. It will stimulate production of both neutrophils and the monocyte cells. Then we have the factors which act on the megakaryocytes, the thrombopoietin factor agonist are there. We have the romiplostin and thrombopac. So coming first to the recombinant erythroid growth factors, the intravenous administered recombinant erythropoietin has a half-life of 4 to 13 hours, and it increase in the reticulocyte count occurs within 10 days if given daily. But detectable increase in hematocrit takes 2 weeks, and it prevents programmed cell death of erythroid progenitor cell. This is a mechanism of action. So erythroid growth factors, they were FDA approved way back in 1989. They are produced by interstitial peritubular fibroblast kidney cells, small amount by the liver also. Hypoxia-inducible factor, I'll explain this, increased transcription, and blood levels depend on rate of transcription. There is no storage form. As soon as the erythropoietin receptor, it binds to erythropoietin receptor, the receptor gets internalized into the cell and gets degraded. So there is no storage form. They are excreted by the kidney, so those has to be, we have to check the dose while giving a patient with CKD. So coming to the mechanism of erythropoietin, how it acts. So in the renal cortex cells which are producing erythropoietin, we have the hypoxia-inducible factor 1 alpha is there. When normoxia is there, means sufficient amount of oxygen is there, iron is there, So in presence of these molecules, there's an enzyme which causes the proline hydroxylation of this molecule. When this hydroxylation occurs, it binds to the von Hippel protein by ubiquitination pathway. It gets degraded. So no erythropoietin is released. When hypoxia is there, then HIF, this oxygen is not there. Now hydroxylation, proline hydroxylation will not take place. HIF1 beta, some call it 2 beta also. These two combine and uh, then they bind on to the DNA segments of the cells which produce erythropoietin. So cause upregulation of the hypoxia response genes. So then more of erythropoietin is released and it acts on the bone marrow cells. These are the cells which are dependent on erythropoietin. I think from CFU persists till late basophilic stage. I think up till here it's stage. So when the erythropoietin binds to erythropoietin receptor, some conformation changes occur in the erythropoietin receptor, gene transcription occur. So it is anti-apoptosis. The cells which are going to get programmed cell death, they do not die and they proliferate and leads to more of production of red cells. Even one pathway by the RAS and RAF pathway, the proliferation also stimulated. But one thing important here is after this molecule binds to the receptor, this receptor gets internalized and it is degraded. So this diagram is, we have two types of recombinant erythropoietin molecules. One is epoetin alpha and the apoetin alpha. They differ in the amount of carbohydrate side chain. It has 3, it has 5. Because of these 2 extra carbohydrate chain, the shelf life and the in vivo half-life of the molecule increases. So epoetin alpha, it is a glycosylated protein, carbohydrate available in pre-filled syringe and vials. It is FDA approved for CKD, chronic kidney disease, when kidney is not producing enough erythropoietin. Patient on chemotherapy for solid tumors, lymphoma and myelomas. Decrease erythropoietin levels in HIV patients within myelosuppression due to chemotherapy, perioperative and as I already discussed, preoperative autologous donation when you have to increase the red cell mass. It is subcutaneous more effective and T half is 8.5 hours. In this, the arbopoietin, because of 2 extra carbohydrate chain, in the first line, T half has increased. So third line I'm reading, increases half-life number of salicylic acid residue increase. Indication remains symptomatic anemia in adult cancer patient with non-myeloid malignancy receiving chemotherapy. Adverse effects are hypertension, seizure most common, thrombosis is very common, serious complications are there, decreased survival hemoglobin more than 12 in cancer patient. So antibody-associated pure aplasia may also occur. Like antibodies are produced against erythropoietin and the receptor get internalized. So these are the main side effects, but practically I've seen patients developing high blood pressure and thrombosis. No other complication I have seen in patients who had received erythropoietin. This a new molecule, even I read about this molecule today only, sotatercept A011. It's a recombinant human fusion protein. Administration to healthy volunteers leads to rapid sustained hematocrit rise. And the mechanism is different from erythrocyte stimulating agent, which ESAs act on the early stages of erythroid development. But this molecule, it acts by trapping growth differentiation factor, a ligand that binds to ACTR2A and impedes terminal erythroid maturation. So one difference main is the erythropoietin stimulates the earlier stages, and this molecule, it stimulates the erythroid maturation, the late stages. So one more molecule, lespetrecept A53, has also been developed. It is phase 1 trial. Now coming to the myeloid growth factors, we have already discussed, we have 2 types, GCSF and GMCSF. Main difference is it will proliferate only the neutrophils. GM will proliferate monocyte, eosinophil, other molecules as well. Most commonly used is filgrastim is being used, can be given IV or subcutaneously. It rapidly mobilizes neutrophils from the marrow's reserve. It increases neutrophil 3 to 4 fold in 4 to 6 hours. And continuous infusion leads to increased percentage of circulating band neutrophils with more deeply standing primary granules because they are being rapidly produced now. So GMC we already discussed. The example is cedramostin, which is used, and filgrastim. It is used for febrile neutropenia in patients with non-myeloid malignancies. Even for myeloid also they are using. Reducing time of recovery for AML patients on induction chemotherapy. Mobilizing hematopoietic progenitor cells into peripheral blood for collection by leukapheresis. It is being used in a blood bank. When we require granulocytes from a donor, then we give filgrastim. So within 5 to 6 hours, the leukocyte count increases. So we can take out more of neutrophils. Even when stem cell collection are being done, still this molecule is being used. Congenital neutropenia, cyclic neutropenia are the indications for filgrastim. Increased survival in patients acutely exposed to myelosuppressive doses of irradiation. So it is given. These are all the indications for the granulocyte transfusion. If granulocytes are not there, then you can use this molecule. So it's an alternative to granulocyte transfusion. Adverse effects are the bone pain, most common. Patient complaint of nausea, vomiting within 15 minutes of giving the filgrastim. Pre-inflammatory condition, exaggeration occur. Then allergic reactions are there. Antibody formation occurs, which can neutralize the further dosage. Then alveolar hemorrhage, hemoptysis are seen. Myalgia, fever, and the last one, first dose phenomena is very important. Happen, but it happens. Sometimes we have to discontinue the treatment with filgrastim. Hypertension, tachycardia, dyspnea occurs. So after myeloid, we have the thrombopoietic growth factors. Its structure is very similar to erythropoietin, and absence of thrombopoietin gene or receptor. It reduces the platelet count, megakaryocyte count, megakaryocyte precursor count to 10 to 50% of normal. It is synthesized by the liver, inversely related to platelet production, cleared from blood by high affinity platelet TPO receptors, leaving small basal amounts. No specific center sensitive to platelet count in the body. Like if for EPO, we have the renal cortex, but here there is no specific center. Increases in aplastic anemia, decrease in hepatic cirrhosis. That's why patients with the liver failure, they have thrombocytopenia. Transfusion of platelets. That's why in patient nowadays in North India, so many dengue patients are there, and platelet count falls. And now we recommend that we should not transfuse unless patient bleeds or the count is less than 10,000 threshold. But still patients are being transfused. When you transfuse a platelet, the thrombopoietin factors goes down. So the recovery is delayed. That's why we should not use the platelet irrationally. Then bind with TPO receptors on target hematopoietic cells. We all know it amplifies the megakaryocyte lineage by mitosis of megakaryocyte CFC. Megakaryocyte endomitosis and maturation occurs and increase in the production is there. Then thrombopoietin growth factors, which we have, are the recombinant human TPO, RHTPO we call, and the second one is a pegylated recombinant human megakaryocyte growth and development factor. It differs at the site at which it acts. It increases the platelet count in healthy subjects and the yield of platelet apheresis, raise baseline platelet count and decrease transfusion after non-myeloablative chemotherapy, minimal effect on recovery of platelets, more than 20,000, need for transfusion leukemia induction therapy or stem cell transplantation, antibody developed against PEG RH MGDF, cross-reactive TPO causing thrombocytopenia. So it can cause autoantibody formation as well. So we have the various drugs, romiflostin and trombopag. They are non-antigenic potent platelet production stimulator and it was FDA approved for ITP in 2008. Romiplastin, also an end plate, it's a TPO receptor agonist, T-hyphen 120 hours, which is 3 times the TPO. While are in a lyophilized state, dosage is given and it is used for patients who are not responding to corticosteroids or immunoglobulins or splenectomy. And platelet count increases on day 5, peaks on day 10 to 15, and return to baseline by day 28 because it's a long T-half. Then we have the Anthrombopog, also known as Promacta revoldi. TPO receptor activator increase megakaryocyte growth and maturation, platelet count, whereas it is available in the oral form, metabolized by liver. It came once a day after the food, distance from calcium. These are all the dosage. Rise of platelet is 1,50,000 above baseline during the peak when this drug is given. It is being tried in dengue as well. Some people are giving it dengue, but it's off-label use. It is not to be used for dengue patient unless or until it is patient is bleeding and we don't have the platelet transfusion. It is these are the indications which are there: thrombocytopenia in adults and pediatric 1 year older with chronic ITP who are not responding to corticosteroid, immunoglobulin, splenectomy. Chronic hepatitis C to initiate and maintenance of interferon-based therapy, and for severe aplastic anemia who had insufficient response to immunosuppressive therapy. So adverse effect of thrombocytosis, if given more thrombosis can occur, increase bone marrow reticulate only with romiplastin, not with any other drug. It can stimulate the leukemic blast as well, autoantibody formation, rebound, worsening of thrombocytopenia in ITP patients. When you stop the drug, there's rebound thrombocytopenia occurs. Then this is again a new drug including 11 Oprelvicin. It is FDA approved for prevention of thrombocytopenia following myelosuppressive chemo in adults with non-myeloid malignancy, and fairly large more side effects are there. So these are various preparations which are available. There's a filgrastim which are using in PGI also for inducing the production, for accelerating the production of granulocytes. This Altrambopag tablets are there. You can see 25 milligram tablet is there on the right side. Now, after the recombinant factors, we have the pharmacological agents also. These do not accelerate the production of red cell or platelets or other cells in the blood, but they decrease the blood loss. So if they decrease the blood loss, the requirement of blood decreases. So in a way, it helps. It's an alternative to the blood transfusion. Antifibrinolytic drugs and procoagulant drugs like tranexamic acid is there. It's an antifibrinolytic drug. Aproctenin is there, which reduces the blood loss. EAC is there. Epsilon, I'll come to this. Epsilon aminocaproic acid. Tisosacilants are there. Recombinant activity factor 7 is there. Desmopressin is there. Danazol is there. Intravenous immunoglobulins are being used. Vitamin K. I'll discuss each one of these agents. First is a tranexamic acid, Trenexa. It has been extensively used in PPH patient, in trauma patient, where trials have been done, like CRASH 2 trials was there. It says that within 3 hours, if you give in trauma patient, the bleeding is less. In the women trial, they say if you give within 3 hours of start of bleeding, the chances of patient postpartum hemorrhage goes down. Molecule is a synthetic lysine derivative. It inhibits fibrinolysis, inhibits the breakdown of clots by reducing the conversion of plasmin to plasminogen. It reduces both the risk of receiving a blood transfusion by around 30% and need for further surgery due to rebleeding. So it prevents a rebleed also. So if the patient is on Trenexa, then the chances of that patient will bleed into the drain is also less. So post-operative salvage is not required if we are giving this drug. So this is a very good drug which is being used. Aproctenin, similar drug. It's antifibrinolytic, but mechanism is a bit different. It inhibits many proteolytic enzymes and reduces fibrinolysis. Bovine in origin can cause allergic reaction. It is mainly using cardiac surgery, where it's found to be more effective. It is more expensive. Chances of thromboembolic events are more. So it was temporarily withdrawn because Trenexa was there, which has very good safety profile. Also, chances of coagulation was thromboembolic events were less. So if we have a good drug as compared to proteins, then why to use this drug? So it was withdrawn, but recommended in some group of patients with high risk of bleeding. Then ESCA, the epsilon aminocaproic acid, it's again antifibrinolytic activity, but the difference is Trenexa was inhibition of from plasmin to plasminogen, but this inhibits the formation of plasmin by blocking the binding of plasminogen on fibrin. It will not bind on the fibrin. So it is useful in clinical conditions where primary fibrinolysis contribute to bleeding. It is used in obstetric bleeds, post-prostatectomy hemorrhages, and is contraindicated in patients with DIC where fibrinogen is necessary to maintain organ function. Because in DIC, it's like fibrinogen is being consumed to form the clots. So both are causing the pathology in such patient. So if you block the fibrinogen, one pathway will be stopped, and then there will be lot more chances of bleeding in patient with DIC. That's why it is not used for patient with DIC. Tissue sealants are there. You must have seen some sprays which are being used nowadays on during at the site of surgery. They are derived from human or animal clotting factors such as fibrinogen, sometimes activated by thrombin in the syringe immediately before administration, or synthetic hydrogel polymers are there. They are sprayed on surgical fields or raw surfaces to promote hemostasis and reduce blood loss. And the trials have shown that they can reduce surgical bleeding and exposure to donor blood, the effect being more significant in orthopedic surgeries. But they are being used in the surgical procedures, open wounds to control the bleed. Then comes the recombinant activity factor 7A, available in the market at Novocet. It's written Novo 7. It's Novos. This let me correct this. This is Novo 7, and the trade name is Novocet. It directly active. If you remember, we have the two pathways, classical pathway and the cell-based model pathway. If we go by the cell-based model pathway of coagulation, it directly activates blood clot formation at sites of exposed tissue, factor in damaged blood vessels, bypass other clotting pathways. With platelets, it binds, and with factor 7, it activates the coagulation. It is only licensed for the treatment of bleeding in patients with hemophilia A or B with inhibitors. But more than 95% of it used worldwide. I've seen in India also it is being used off-label in patients with major hemorrhages. And there are reports with conflicting results, but even I have seen patients improving after giving factor 7. But it's a costly drug. The main off-label uses are in cardiac surgery, trauma, intracranial hemorrhage, and liver abdominal surgery. And acidosis, common in major traumatic hemorrhages, reduces its effectiveness, and adequate level of fibrinogen are needed for clot formation. So it's always advisable that before you give factor 7, you must do the sonoclot or thromboelastography so that you know whether fibrinogen levels are low or not. Because fibrinogen level take 12 to 14 hours maybe for the reports, but thromboelastography results you get in 5 minutes. So you must get those things done before you give this drug for major traumatic hemorrhages. Then desmopressin is there. This is a drug. It causes a release of factor 8C and von Willebrand. It is being used in von Willebrand disease to increase the level of von Willebrand factor, but it is can be tried in patients with platelet defects and uremia when platelets are not functional, because function is less. Main role of function is to bind to the endothelium to the von Willebrand factor. So if this drug is given the functional status of the platelet, sometimes in patient with uremia, the platelet count is normal, but patient still bleeds because the platelets are defective. They are not working properly. So in those conditions, desmopressin is indicated if we do not have the, because in uremia, after there is no indication to transfuse platelets because count is 2 lakhs. If you transfuse platelets, the same defect is going to be acquired by the transfused platelets. So there is no use. But this drugs may help. The template bleeding time is shortened within 60 minutes and the effect lasts less than 24 hours. Repeat dose may be less effective as stores of 1 million factors are depleted in the endothelium. It may cause headache and facial flushing sometimes. Danazol is a synthetic androgen. It is being used in ITP. And it may also stimulate an increase in hematocrit in some patients with autoimmune hemolytic anemia. However, it is not, I've never seen this drug being used for AHA. Vitamin K, a very important molecule. Vitamin K dependent coagulation factors are there. Factor 2, 7, 9, and 10 are there. Vitamin K get deficient antibody use, obstructive jaundice, fat malabsorption syndrome. So a patient who comes with trauma or bleed or obstetric hemorrhages, if liver function is adequate, then we can give vitamin K, because if these factors are lost during the bleed and they are not being replenished because of deficiency of vitamin K, so vitamin K helps. So it's advisable to give vitamin K in all the patients where you're suspecting decrease in the coagulation factor activity, provided their liver function is normal. So at the end, when we sum up all the alternatives to blood transfusion, so initially I divided them as red cells, the blood substitutes, hematopoietic growth factors, and the pharmacological agents. Now at the end, let's summarize it as the factors which can be used as alternative to red cell, alternative to platelets, to plasma, to granulocytes, or to prevent the blood loss. So for red cells, you can use the red cell substitutes. Few of them are in the last stages of their trials. Recombinant erythropoietin you can use. Then iron administration. Patient is in preoperative phase. The surgery is postponed for 2 months or 3 months. You can give iron. That will help to increase the hemoglobin level. Then danazol is a drug too for use for AIHA. Then for platelet, we have again the platelet substitutes, thrombopoietin growth factors, and IVIG. In ITP, intravenous immunoglobulins are being used that help to increase the platelet count. Because in ITP, if you give platelets, after 1 hour or 2 hours, those platelets are going to get destroyed. So, as such, there is no indication in ITP to increase the platelet count by platelet transfusion. So, but IVIG helps because it's an immunomodulatory molecule, and ITP is due to some autoantibody formation. So, IVIG helps in patients who are refractory to steroids in ITP. So plasma alternatives are tissue sealants are there. The sprays which are used containing fibrinogen and thrombin. Factor complex concentrates are there. As we know, initially people were using fresh frozen plasma cryos for hemophilia and von Willebrand disease. But nowadays we have the factor complex concentrate. Factor concentrate is there, so it can be used as a substitute for plasma transfusion. Then vitamin K, it will replenish the vitamin K dependent factors. Then granulocyte myeloid growth factors are there, filgastrin is there. Then to prevent the blood loss, we have the antifibrinolytic drugs and procoagulant drugs, tranexamic acid, protein. ESC again, it's antifibrinolytic. Desmopressin is a drug which increases the von Willebrand factor in the endothelium and increase the hemostatic activity of the platelets. At the end, 2 or 3 lines about the patient blood management I want to discuss, because patient blood management is a patient-focused, multidisciplinary, evidence-based and systematic approach to optimize the management of patient and transfusion of blood products for quality and effective patient care. Systematic approach, decision-making, transfuse only when it is required, include patient evaluation and clinical management with use of appropriate indication and triggers. If you use appropriate indication, again, it will reduce the requirement of blood. So again, it's an tool for blood conservation, and it can call as an alternative to blood transfusion also. So it's minimizing of blood loss, optimization of blood patient on red cell mass, minimization of blood loss by using various drugs, and optimization of patient own red cell mass like erythropoietin can be given, iron therapy can be given. So scope of PBM is to improve patient safety and outcome by appropriately managing the patient's own blood and by minimizing unnecessary exposure to allogenic blood products. I'm not going into the detail of patient blood management here, uh, as I've already discussed this in my previous classes as well. So I just want to show this slide in perioperative patient blood management. Like, first, optimize red cell mass. So here you will see identification and management of any underlying condition causing anemia. You can write here preoperative autologous blood donation can be there, treat with other hematic deficiencies, then minimize blood loss, then harness and optimize physiological reserve of anemia. Acute normulemic hemodilution can be done in the intraoperative phase. The surgery, times surgery to optimize the hematological parameters, proper hemostasis and surgical technique, blood sparing surgical devices are there. Autologous blood options are there in the intraoperative cell salvage, as always discussed. Optimize the cardiac output, optimize ventilation, oxygenation, because main function of red cell is to transfer oxygen. So if we increase the partial pressure of oxygen which is being given to the patient, in that case, our blood requirement may decrease. So you have to see the patient and manage the patient as whole. Post-operative, you can optimize the erythropoiesis. If you are doing more of red cells, you are suppressing the erythropoiesis. Then vigilant monitoring and management of post-operative bleed. Here you can say post-operative cell salvage also can be done. Maximize oxygen delivery and minimize the oxygen consumption. So at the end, just again the same alternative blood transfusion. I started with autologous blood transfusion. In that, the patient's own blood was being used. Then hematopoietic growth factors I discussed. In that, we increase the production of patient's own blood by giving hematopoietic growth factors. And third, we have the pharmacological agents which decrease the blood loss, so preserve patient's own blood, so that the requirement for the allogenic blood exposure goes down. Thank you so much. Thank you.
Thank you, Dr. Lakhvinder. Please, we should just stop sharing so that we can see you. Yeah, wonderful. Excellent lecture. Content is extraordinary, and the way you explained and you have put the things together wonderfully well done. Excellent. And to tell you the truth, I have
Yes.
learned something absolutely new. I knew nothing about it. From
Thank you so
A
much.
to Z, everything is new to me, and I never knew that it was in such details. Wonderfully done. Excellent. You are really an expert in this blood transfusion medicine. Excellently done. Very nice. And everybody who will listen to the recorded version will gain so much. If you allow me, I would like to share your email ID with the students because they may
Sure.
have some queries so they can directly get in touch with you.
Yes, so they can you can share my email ID, and I'll be happy to answer if there are any queries.
Yeah, because these queries keep coming over and over. So, and I know very little about transfusion. I think I only know the spelling. It is such a huge branch, and I am not at all competent to answer even one question. So whatever comes my way, I will share the email ID. So whenever the students go through these lectures and they have any queries, they can go back to the expert directly and talk to them.
Thank
And
you so
I
much.
would also request you to please share the PDF. It will be very wonderful for the students.
Yes, I'll do that.
Dr. Lakhvinder, it was very nice to start the post Diwali sessions with you. Wonderful lecture. God bless you.
Thank you
Very
so
well
much.
done. Thank you so much.
Thank you.
Take care. Bye bye.
Thank you, sir.
Good
Thank
night.
you. Bye bye, sir.
Bye.